Good morning, and welcome to the 2020 coding changes for long-term EEG video EEG services from the National Association of Epilepsy Centers and the AES. It's also termed a year later because we gave a similar session last year, so it's an update to that. But also, we'll have some new changes for you. I'm Nathan Fountain. I'll be moderating today. I'm professor of neurology at the University of Virginia, where I direct the comprehensive epilepsy program. And important for today's talk, I was formerly the president of the National Association of Epilepsy Centers during the time that the video EEG changes occurred. Throughout our discussion today, be sure to enter your questions in the chat box. We'll try to get to as many as we can during today's talk. We've left time at the end for questions because traditionally there have been quite a few. And we want to make sure that we have an opportunity to answer all of those. But in addition, after this session today, there's a separate session called Meet the Speakers at 1:15. So between 1:15 and 1:45, we'll also have another 30 minutes to have discussion as well as answer questions. It's a little bit complicated if you're not familiar to find it. So in order to get to the Meet the Speakers session, you have to go to the AES platform and look on the left side menu for short topics. And under short topics, you'll find a little box for Meet the Speakers. And in the Meet the Speakers room, I guess we call it, you can select the Meet the Speakers for this session today. Our learning objectives are first to understand the history of the long-term EEG and video EEG monitoring codes, which I'll just call video EEG, but I recognize it encompasses more than that. And also its impact on epilepsy care and the reason behind and the processes for the coding changes that became effective last January, so January 1st of 2020. So in some ways, this is old news, but I suspect for many of you, you're still interested in finding out more about that. The second objective is to know the definitions and how to use the new video EEG codes and their impact on patient care. So I'll address the first part, and the second part we'll address in a separate talk. And then finally, the third objective is to know the proposed changes to evaluation and management code reporting and the values, as well as other proposed changes to Medicare policies related to telehealth in particular, and other physician services for 2021, which is particularly important. And here's how we'll accomplish that. So I'll give the first talk about the historical overview of coding changes for long-term EEG and video EEG monitoring, as well as the AMA process for revising the CPT codes and their RVUs or relative values. And then there'll be an explanation of the new coding structure and recommended reporting of the new EEG video EEG codes from Dr. Greg Barkley, who's epileptologist at the Henry Ford Hospital, and very importantly, has been a long-standing member of the RUC. I think I have that right, although he may correct me. But in any event, it's been intimately involved in the RUC and CPT issues for a long time. And then we'll have a discussion of the proposed changes to evaluation and management coding and RVUs for 2021 from Dr. Mark Newer, who's director of the Clinical Neurophysiology program at UCLA. Dr. Newer has been the AAN representative for a long time to CPT and other things, and also has intimate knowledge of all of these issues. And finally, we'll have a talk about the proposed Medicare policies. And although they're proposed, some of them are actually final or near final on telehealth and other physician services and the patient payment rates for 2021. And that's particularly important because, as most of you know, the conversion factor for Medicare is going down a bit, and that affects us. And that discussion will be given by Dr. Susan Herman, who's director of the Comprehensive Epilepsy Program at the Barrow Neurological Institute, and importantly is now president of the National Association of Epilepsy Centers, and like me was involved throughout the evolution and derivation of the new long-term EEG codes. And at the end, as I mentioned, we'll have time for question and answer, so please enter your questions in the chat. So now let's turn to overview of coding revision process. I don't have any disclosures relative to this topic, but several grants to UVA for clinical trials I'm involved in. I wanted to start with some abbreviations because sometimes this becomes alphabet soup. And everyone probably knows these, but this will kind of get you thinking about how to approach this whole topic. So you'll remember the organizations involved are the AMA, AAN, the National Association of Epilepsy Centers, so NAEC, and ACNS, the American Clinical Neurophysiology Society. CMS is for Centers for Medicare and Medicaid Services, that we typically just call Medicare. CPT stands for Current Procedural Terminology, and it's typically referred to as the CPT manual, and that is the list of all the CPT codes that describe every single procedure we do. If it doesn't have a CPT code, we can't bill it, more or less. The RUC is an AMA committee, and it's the RVS Update Committee, or what you and I would call the RVU Update Committee, the Relative Value Update Committee. PC stands for Professional Component and TC for Technical Component. And you'll remember that in CPT codes, if it's followed by a hyphen and PC, Professional Component, that means it's the physician part of it. If it's hyphen followed by TC, Technical Component, that's sort of what you might think of as the hospital part of it. It's for the technical fee. The HOPS is the Hospital Outpatient Prospective Payment System. And I think Dr. Barkley is probably going to talk about that a little more. The APC is the Ambulatory Payment Classification. And the reason I'm even bringing this up is because while each CPT code may have a PC, a professional component, a TC, technical component, the APC is what provides the technical component for some services, and we'll come back to that. And finally, DRG, remember, is diagnosis related group. And that has to do with grouping together certain diagnoses, such as certain epilepsy in some circumstances that have to do with admitting to the hospital. So we're not going to talk today about anything related to DRG, I don't think. So all of this started in November 2016 when the Medicare Physician Fee Schedule final rule for 2017, so it was identified in 2017, that 95951, that's the old video EG code, was identified as a high volume service. And what makes something a high volume service is that the total Medicare utilization, meaning the number of units billed, you could say, is 10,000 or more claims. So certainly we've had that for a long time. But also the volume growth in claims increased by 100% over 5 years. So when you go up 100% over 5 years, have more than 10,000 claims, it pops to the top to be reviewed. And in fact, in 2009, Medicare claims for 95951 video EG were 53,000. And then by 2014, we're 115,000. So you can see it went up 100%. Notice it only went up a little bit more than 100%. So if we'd stayed under that 100% barrier, at least for that interval, we might not have popped to the top. And if you look at the graph over here on the right side of the screen, this is 2001 up through 2015. And these are the annual units billed to Medicare. And you may not be able to see it, but you can see here that in 2009, which is here, it's the 53,000 units. And then 5 years later, by 2014, you can see it's 115,000 units. So what you can see is this is going up, maybe not exponentially, but more than linearly, right? So I guess exponential to one degree or another. So eventually it was going to be reviewed, whether it's 2014 or 15. And that's probably most likely because of the increase in ICU video EEG, but also because some ambulatory video EEG services were being billed. And so the two of them together increased the volume likely. So CMS asked the AMA Relative Update Committee, so that's the RUC, to review the code. And when that happens, then the RUC seeks input from interested medical societies, in our case, the AAN and the ACNS, who then asked NAEC as a subject matter expert to participate. So in a way, kind of NAEC was the driver of this because we've sort of been the keeper of the code, you might say. So the organizations involved agreed to update the video EG codes before the RUC review. So there's always been a lot of confusion about using, so for you and I, we might think an ICU EEG is different than an EMU EEG is different than a bedside video EEG, for instance. And proposed code changes were considered by the CPT panel at 4 different prolonged, involved, complicated meetings. And the reason there were multiple meetings, it was prolonged and complicated, is for a number of reasons. One is because there was significant industry input and industry from ambulatory EEG testing companies who have a large, from my view, a large presence at CPT meetings. And we were, that is the medical societies, were directed to develop a proposal with corporate partners and EEG technologists, which actually makes sense. But it was very difficult to differentiate services provided to hospital inpatients, which we think are complicated, compared to video EEG in the home, which I would think is less complicated. And industry wanted no site of service differential for technical service. And so it was also difficult for this kind of complicated code set to be understood by other specialists because the panel that reviews this are not typically neurologists, they're obstetricians or gynecologists or endocrinologists or family physicians, et cetera. So it's a little difficult for them to understand our complicated mechanisms. The result of all of that is that in May of 2018, they deleted a number of codes. Importantly, deleted the video EEG code, which meant they had to have a whole new set of codes, of course. Also deleted the 8-channel EEG code, the ambulatory channel EEG code, and prolonged EEG without video. and instead established 10 codes for the professional component of long-term EEG services. And these were differentiated by with or without video. And this actually makes quite a lot of sense. The problem is there are 10 codes for something we might say is across just a few different kinds of services, but nevertheless, there are 10 codes. For the technical component, what the EEG techs do, for instance, now became 13 codes. And you might wonder if they're differentiated by duration and with or without video, then why would there be an odd number? And the reason is because everybody gets a bill for setup and takedown, can't do an EEG without setup and takedown. Then after that, there's a certain technical component that has to do with actually reviewing or taking care of or maintaining the EEG, you could say. So all those additional codes are differentiated by the length of time of the EEG and the level of monitoring, something that wasn't really part exactly of the previous codes. And so this is really a simple shorthand way to look at the new codes. This is from a pocket manual that the National Association of Epilepsy Centers developed and really breaks it down very simply. So if we think about the previous video EEG code, 95951, that everyone is so familiar with, in these terms, it now becomes 95720, just to kind of orient you. But across this whole spectrum, you can see that it's broken down by duration of EEG. So 2 to 12 hours, that would be a limited EEG. 12 to 26 hours, typically 24 hours, that would be what we usually do in the hospital. Then 36 to 60 hours, typically 2 days, that'd be an ambulatory EEG for 2 days. 60 to 84 hours, typically 3 days, another ambulatory EEG, or greater than 84 hours, so 4 or more days, which would also typically be an ambulatory EEG. Now, at first glance, this looks like if you have someone in the hospital for 3 days, you're going to build this code, but of course that's not the case because each individual EEG is only 24 hours. The second thing you might ask is, well, why is this 26 hours? And the reason is because if you do a 24-hour EEG, the thought was by the panel that it takes a couple of hours to break it down and so forth. And so if you just do a single session, it would go up to 26 hours, but each individual block is 24 hours, the first of the complexities. Furthermore, beyond the duration here of the EEG, it's also whether it's EEG alone or EEG with video. And that also makes sense, except some of these we almost always use EEG for. It's very uncommon, although still sometimes done, to do EEG alone. So if you look at this for common purposes for physician billing for their services, what we typically bill is sequential 24-hour blocks of video EEG. And then let's say on the last day, it's only part of a day. So you'd bill the last part of a day between 2 and 12 hours using this code, 95718. So these are the two main codes we'd use in the hospital. But for the intention is that for ambulatory video EEG, you'd bill these codes. And for ambulatory EEG without video, you'd bill these codes. So for example, at our institution, we typically don't do video. We do sometimes, but typically don't. And we typically do it for 3 days. We'd often use this code. If it's for more than 4 days, whether it's 4 days of ambulatory EEG or 10 days of ambulatory EEG, it's still just billed this one code, as long as one continuous recording. Now, the technical services are listed down here by duration of the EEG and whether or not it's monitored, whether it's EEG alone or whether it's EEG with video. So let's think about the typical hospital inpatient where they'd have 24 hours of EEG with video. Well, first of all, everyone gets billed a single code for the setup and takedown, because whatever kind of EEG you do, you're gluing EEGs, the wires on their head, etc. So that's this code, 95700. Then a typical inpatient setting, the duration of EEG would be typically 24 hours and be typically monitored continuously. So a monitor watch or an EEG tech, somebody watching the EEG at all times. And so for each 24-hour increment, you'd bill this, 95716 for the technical component. Now, remember, you can bill it all you want, but if they're in the hospital, it's not paid that way, right? It's part of the whole lump sum the hospital gets for hospitalization. So for inpatients, this really doesn't matter for actual transfer of money under normal circumstances. And let's think of the opposite situation where someone comes into the EEG lab, has an ambulatory EEG, and then goes home. In that case, it would be EEG alone. And let's say you did it for 24 hours. They put it on, they came back. Well, that would be unmonitored, and so the technical fee would be billed here. If in fact you did it for some short time in your EEG lab for 12 hours as continuously monitored, let's say, or more than 12 hours, it would be here. So we'll talk more about these details, but I want to describe the rubric of how this is all broken down in this, what I think is a relatively simple manner. So how the codes are valued. are listed here. And all CPT codes are assigned a value called the RVUs, as most of us are familiar with. And they have 3 different components, which I wasn't familiar with before this Odyssey. We think about the physician work, the work RVU, and because that's the one that actually we're able to modify or change because it depends on how much work you do for the service you provide. But also each one has a practice expense and a malpractice expense. The physician work includes the time it takes to perform the service. That's what you would think, right? If someone asked you what you're doing, that's time it takes to do it. But it also includes the mental effort and judgment, what we might say is difficult it is, the technical skill and physical effort. Physical effort's not so much for us. It's one finger on a keyboard typically. And the physician's psychological stress that occurs when an adverse outcome has serious consequences. So for epilepsy surgery, that's quite important. Maybe for some others, it's not. But it's all these things together that go to the physician work. The practice expense has both a direct and indirect practice expense that's based on all these things. And as far as we're concerned, what's important to know here is that there's a certain practice expense that has to be derived for any new code. The malpractice expense has a specific formula and is determined by specialty and by CMS, and we don't really have any influence over. So if we look now at the old 95951 code, because that's easy to understand, I realize it's all done, that's history, but nevertheless, to get a frame of reference, here it is. So 95951, we got 5.99 RVUs for work RVUs. That was based on how much work it took to do. The practice expense was 2.82, and the malpractice RVUs was 0.33. So you got a total of 9.14 RVUs each time you build to 95951. Now, how much of that was practice, was a professional component and technical component? Well, it was all technical component. There was no such thing as 95951-26. I put it here just to illustrate the point. It was all professional component. There was no technical component because there was no point. It was always done as an inpatient. It was always done in the hospital. It had no separate technical fee because you can't bill things under normal circumstances in the hospital. So it's just a single global code. And remember that this RVUs, if you want to relate it to dollars, you have to multiply it by a geographically adjusted conversion factor, which is typically around $38. Historically was around $38 and adjusted geographically. So for instance, Virginia's classified in the South, and that's the lowest geographic adjustment. So we get relatively less than someone who is in, say, New York. So to value the new code set, the new one, so after 95951 was deleted, we had a new code set. The AAN was surveyed under the direction of the RUC in 2018. And so you and I were asked to provide time and intensity of the new codes by comparing the codes to reference codes. They said, okay, how similar is this experience of this kind of video EG to something you're familiar with, like a new clinic visit or something like that? Surveys were sent to 2,000 physicians and 150 physicians returned it. And that's really not too bad. So apparently for the RUC to get 150 responses is pretty good. The RUC made recommendations for the physician work units, and that drove the assignment of the RVUs. And so here's how it worked out. As of the last time it was reviewed in 1995, the pre-service time was 30 minutes, the intra-service time was 60 minutes, and the post-service time was 60 minutes, so 150 minutes to perform a video EEG. Remember, this included taking the VCR tapes and putting in the VCR and going ahead to point 352 on the VCR, which corresponded to 1017 of daytime. So you go back and look at the change and blah, blah, blah. So it's a very complicated, time-intensive process. And that's how the work RVUs came up to 5.99. When it was reviewed here in October 2018, we said, the community said it took 10 minutes of pre-service time, 55 minutes of inter-service time, and 15 minutes of post-service time, or 80 minutes. And so that led to work RVUs of 3.86 RVUs. When you view it like this, it really does seem rather fair or appropriate from a sort of a, organizational perspective. It's very painful to go from 5.99 to 3.86. That's a 33% cut. But from this perspective, it sort of makes sense. It's pretty hard to justify 150 minutes for each video EEG we do. And this is actually the result of the review for the code. So we said that the survey predicted the mean was 5 RVUs and the 25th percentile should be 3.5 RVUs. And so it should have been at 3.5 RVUs, but all of you and all the organizations lobbied CMS and everyone else to make clear to them that when we took this survey, we had no frame of reference for knowing what we were talking about because this is a brand new code. And so actually that's how we ended up at 3.86, which is actually a relative win. So another way to look at this is, where did we live before and where do we live now? Well, if you look at 5.99 RVUs, so previous where we were before, that was similar to right and left heart catheterization with ventriculography. And you know, you can imagine that's a pretty serious business that takes a while. So it seemed like we were a bit overvalued. It was similar to revision of eyelid or realignment of tendons or laparoscopic tubal cautery or shortening of hand tendon. And if you look at where we live now, it's still pretty good. So we're with partial removal of toe and transfer of embryo, similar kind of work, and also initial hospital care, 3.86. Now, remember, I said the surveys are compared to something else we do. The most RVUs that a neurologist can get for anything they do as part of their regular practice is initial hospital care or ICU care, which are both at about 3.86 RVUs. And that means that from my perspective, from now on, the most any neurology procedure could get under normal circumstances, because the comparator for the highest value is initial hospital care, it'll probably be very, very difficult to get more than 3.86 RVUs for any procedure in neurology. But nevertheless, I also think that's fair, because just as the Medicare utilization has gone up exponentially, so has it all of our centers. So when your administrators say, oh my gosh, it's 33% less than last year for video EEG, well, remember, we're doing 2 or probably 3 times more video EEGs now than you were 5 years ago. If you're like our institution, certainly more than 7. If we go back 7 years, definitely 3 times more. So the RVUs went down 33% over this time per test, but the number of tests has gone up 200%. So the total value of dollars compared over long term is still quite a bit more. So that's sort of my parting shot of positivity of how it's played out. And now I'll turn it over to Dr. Newer.
Dr. Barkley is actually next.
Oh, I'm sorry, Dr. Barkley. My apologies, I should have known better.
So let me get the screen share up here, and while doing this, so we'll go through my slides. Thank you for that introduction, Nathan. What I'm going to do is to talk a bit about these codes in a bit more detail, so a little more granular look at those. I have disclosure that I'm involved with the MONEED project. The learning objectives for this section is to understand these code changes, and really I'm going to focus in on the 10 new professional codes and 12 new technical codes, and describe when you use the 95700 technical code, and then also talk a little bit about the funds flow between professional and technical coding depending on site of service. So Nathan also showed that these old codes were deleted, and what is unusual about these codes is before we would use a single code, and it would include both the professional and the technical component. But now with this new set of complicated codes, we now have to separate with a different code for the professional component and 1 or more or 2 codes for the technical component, depending on the circumstances. So let's talk a bit about how coding is done, and we're going to start at the simple situation and move to the more complex. So at the simple situation is the bottom of the slide, which is an outpatient private office where one bill is submitted called a bundled fee, which includes both the professional component and the technical component. That's called global billing. Both the technical component and the professional component are determined at the RUC committee by this very laborious method of bottoms up, taking into account the time of everyone involved in terms of the physician or other health care provider, and or all of the technical staff and the supplies and the equipment. And then the RUC values that and sends those suggestions to CMS, and then they use that to determine how much of that information they're going to accept, and then modify that a bit in some of the codes. The other two situations are applicable to many of the people in the audience, and those are folks who work either on inpatient services or in outpatient services. So Nathan talked a bit about the inpatient hospital work, so that no matter where you are, you still will pick a professional fee. Now, when you are not in a private office, you have to designate the professional component, usually by using a 26 modifier, if say for the evaluation and management code. But in this case, because there's a unique professional code, the 26 modifier doesn't apply here. So that's one of the things that has been a stumbling block in some of the billing that has happened this year. The technical fee in the hospitalized patient is tracked, but when the payment comes back from CMS, it's only made as a single DRG payment that can be boosted by comorbidities and complications of the hospitalization. And then annually, each hospital submits a report to CMS of what they think the costs are for providing all the supplies and services for hospitalized patients. And so eventually there's a trickle down effect that these hospital reports are then filtered within a few years into modifications of the DRGs as information and data accrue. In medical centers where provider-based billing or facility-based billing is performed, we have a similar split where the professional fee is paid to the physician and the technical fee is paid to the medical center using the HOPS. And then the ambulatory payment classification is a way it can be thought of as kind of an outpatient DRG system where similar procedures are lumped together into a single payment that's similar. So in the EEG example, all of the short EEGs map to the same APC. For these new EEG codes, they map to one of 3 different APCs depending on which code we're talking about. So this has some implications on how much the technical payments come back to your facility based upon how much the intensity of monitoring is. And the APCs are modified in the payments every year, and there's some reclassification that is done by CMS. So eventually there's a trickle down of the changes in expenses that is seen throughout the system. So when you look at the CPT book, which is owned by the AMA and is their largest source of revenue, you see a series of instructions and guidances about the new EEG codes, which are now listed on the right-hand side of this screen. And we'll go through those in detail. So let's talk first about the professional codes rather than the technical codes, even though in the numerical order, the technical codes come first. So as Nathan said, we now have 10 new physician codes for these services, and they're all based upon the time of the service of the recording. And the definition now includes some more specific directions. It's to review the recorded EEG events. There's analysis of spike and seizure detection and ICU trending with an interpretation and report. So notice that spike and seizure detection and trending is inherent in the code. We'll get back to that later. What's also important to know is that you can also build an E&M code on the same day and report that separately. So let's say you're in the epilepsy monitoring unit. You can both make a patient note that day as well as the EEG report and put your name on both reports and get paid for both of those. And in fact, if that patient happens to be one in whom you are doing cortical stimulation, you can also make a separate report for that on that same day. But you have to be careful that you separate the time of cortical stimulation from the time of the professional component of the EEG code so that you aren't looked upon as being a double dipping of the same time being used for 2 different services. But that's simple enough to do. So in these codes for the professional component. As I mentioned, there's the duration of recording. Another factor that is used to determine which code to use, when is the report generated, meaning on the same day or after the fact, and whether or not there is video. It's also important to know that for the same day recordings, the physician needs to have access to the EEG and video data during the recording as part of the definition of those codes. So Nathan showed one way to conceptualize this. This is another way to look at this. So I've separated on the left-hand side all the codes with video, and on the right-hand side all the codes without video. And then down the middle is the column of duration of the recording, so that 95720, the second one, second row, is the replacement for the 95951, the 24-hour video EEG code, with the top line being the 12-hour code or less, and then the longer codes being the subsequent codes. For the shorter codes, the code that with video would be 95718. It would be unusual for us to use 95717 as an epileptologist. And this is said for a continuous EEG with the spike and seizure detection, as mentioned, with video for 2 to 12 hours. So this has a couple times in which this can be used. One is this can be used if you have a short recording lasting less than 12 hours. Let's say if you're running an ambulatory video EEG, like an 8-hour EEG in your clinic or your EEG lab, this is the perfect code to use. Prior to this, we didn't really have a code for this, and you had to use a reduced services modifier that may or may not have been recognized by insurance companies. The other time where this code comes into use is when you have a person on a multiple day in EEG monitoring in the hospital, and you come up to the last day and there is less than a 12-hour recording. You can use this one time. I know a number of questions are going to be raised. Well, what about, can you use it on the first day? I think that our experience has shown us that the best way to use this is only on the last day of service, because that fits within the coding regulations. And that does make things a bit awkward, but no code set is perfect. And this one was 5 years in the making, and this is the best that we can do at this time. So let's go to a very specific circumstance. What if somebody has a 25-hour EEG? Then you'd use the single day 95720. But if the EEG goes 26 hours in 1 minute, you've now exceeded the threshold, and you can use 2 professional codes. 1 unit of 95720 for the 24-hour code, and 1 unit of 121 minutes for the 2 to 12-hour code 95718. So you would make 2 separate reports for these 2 codes. In the case of a video EEG, the code for the first 24 hours would be on the day it started, which would certainly be the day before you did the recording, the interpretation. And then for the 95718, that would be the next day, which would be presumably the day you're reading both EEGs. So you'd have 1 report dated yesterday and 1 report dated today as you were making your reports. So this is the mainstay of our inpatient monitoring of 95720. This would be for patients who are on the epilepsy monitoring unit, in an ICU, or even in the ward, or presumably could be in an outpatient service, as long as you had access to seeing the EEG during the course of the recording, seeing the video, and you were making a daily report. So you can use this code every day for as long as it's needed. And we all have had ICU patients, or certainly intracranial monitoring patients, where the admission can go on for a couple weeks or longer. And what your requirement is a daily report done each day And at the end, the last day of the recording, there's a summary that wraps everything all up and summarizes the entire session. Now, there are a new set of codes that take care of the ambulatory codes. And the difference between these codes and the ones I just described is that it is expected that these are codes where the patient is hooked up, sent home, comes back at some later date where the EEG is then reviewed and a single report is generated. Typically, these are 2, 3, and 4 more day recordings, and with or without video, and the codes for the professional component with the video is always the even numbered, and the without is the odd numbered. So this takes care of a very ambiguous situation for which we had no set of codes before. So, so this retrospective review is, I think, helps all of us who are doing the ambulatory studies. Now let's turn and talk about the technical components. There are several new concepts. The first new concept is that you can actually have 2 technical codes for a single professional code in this family. And that's when you use 95700 along with the monitoring code. Another key component is that for the first time, an EEG technologist is defined. The EEG technologist is defined as someone who has special training in EEG, but it does not require the EEG technologist to be a registered EEG tech. But if somebody who, let's say, is working in the cardiology or the EKG lab is asked to put on a head map, the head wrap, and just turn the machine on, that does not count as an EEG technologist. So it's only somebody who's had special training on how to at least measure the head, whether or not you use a cap or not, but they have to have some knowledge of EEG. Now this code can only be used, and the 95700 is for the setup and all the time it takes to set up a long-term recording. And inherent in the code is the takedown. So you only use it at the setup, day 1, and never again. So that takes care of the setup, but it doesn't take care of the actual code itself. And the taking care of the code itself is defined by the next series of codes, which include all the effort that the tech needs to do of following the run of the EEG, the fixing of electrode artifact, the transfer of data from one server to the other, screening the recording if that's done according to the rules and regulations of the hospital and state in which the practice is done. And then these codes are further broken down by the intensity of the monitoring by the techs to try and capture the cost of what is actually being done. So in this table, I've broken this down in a similar fashion. So I have with video on the left and without video on the right, and then the duration of the monitoring is for these codes is per day for the 24-hour codes, and then there's a separate set for the 12-hour codes. So note that this set of technical monitoring applies for the technical services per day for even for these extended 2, 3, 4 more day codes, so that you may have you will have on say a 4-day EEG, you will have a single professional code, but you'll have 4 separate technical codes for each day of monitoring, which may not necessarily be the same code for each day because you may have different degrees of monitoring for various reasons. I'll go into that in the next few slides. So one is that with or without video is one of the discriminators, as we saw. The second is the duration less than or greater or 12 hours. And the third is, what is the difference between unmonitored, intermittent monitoring, and continuous monitoring? So there are several criteria that have been put in place to distinguish these different degrees of work. So continuous real-time monitoring is a very high bar, which requires a maximum of 1 tech to 4 patients, and there cannot be a break in the recording. So if you're in the monitoring unit and a patient goes off for a CT scan or a SPECT scan or something like that, then that is a break in the recording, and this is no longer a continuous monitoring. It becomes an intermittent monitoring. Intermittent monitoring is defined as being 1 tech to up to 12 patients. And anytime there is more than 1 tech to 13 or more patients, that's considered unmonitored. And unmonitored, of course, would be when the person is not being watched at all as well. So the monitoring can be in person, it can be remote from another site, with the video access or EEG for the video monitoring, or for just looking at the EEG when there is no video. So you don't, that is the key for the monitoring is for the using the code with video has to be both EEG and video. If it's just EEG, it can be the EEG without video. And then you have to sort out how many patients you are the tech is watching to be able to determine. Now, with the intermittent monitoring, another barrier is that if there is a break of more than 2 hours, then that is no longer intermittent monitoring, it is unmonitoring. So because in intermittent monitoring, there has to be some sort of notation every 2 hours of something going on by the tech. It does not have to be in the medical record. It could be on the, most places are putting it as a note right into the EEG. And it can be something as simple as just writing intermittent monitoring with a timestamp so that it can be gone back, and if there's an audit, proven that somebody had made an entry every 2 hours or so. In the EEG technical, the services can be for the 12-hour codes are again similar to the rules that they last 2 hours to a maximum of 12 hours. It only can be used once in the recording, just in a multi-day recording, just as the professional component. The CPT assistant addresses some of these things to try help clarify. The question is for inpatients, how should you count the 4-hour periods in monitoring of long-term EEGs? This is probably the most frequent question that arises, and I've been seeing that there have been questions flashing, and probably has to do with this, but the code is per 24 hours. The code is reported once a day. A physician codes for each 24 hours with or without video for the professional component. And then the 2 to 12 hour code is then used for the final day of the recording. The second question that often comes up is, how do you report for the confessional component if more than one physician is involved in the reading? And the directions are that one physician will make the report and the payment is made to that physician. And if several physicians in the same are part of that service, then it's up to those doctors to divide up how they are going to allocate the payment for that 24-hour EEG. And so that becomes a local decision at the discretion of the partnership. So that's kind of the third question is, can you use the 95718 or 720 for an ambulatory video if the data is downloaded every 24 hours instead of a single download at the end of the ambulatory study? And the answer is no, that it would not be appropriate to use either of these studies, because this meets another threshold, which is the medical necessity code. So medical necessity applies to all codes in the code book. And so you could have somebody with carpal tunnel and you order an MRI of the brain. It's certainly possible to do so, but there's no medical necessity to have that because it's a service that is out of proportion to the problem being complained about for the patient. So the medical necessity of ambulatory monitoring is that this is an outpatient service and that the level of intensity of the service does not require a daily use of the 95720 and the one-time use of 95728 for a video monitoring of those patients. And instead, while you are able technically to be able to do the professional code on a daily basis, there's no reason to on the basis of medical necessity. So this is the only thing I want to point out here is that because of these codes, there was one minor change in 95813, the EEG that used to say greater than 1 hour, less than 2 hours. It's been shortened by 1 minute just to make things consistent. So it's now 61 to 119 minutes. And that really is only a minor point. And then the final discussion about going back to a point I made earlier about spike and seizure detection is how do you use 95957, the digital analysis? This EEG code is not used for the routine monitoring of any of these video EEG monitoring codes. This is for a special technique such as jerk lock averaging for myoclonus, or dipole mapping, such as in this example that I took from one of my patients, that where you have collected a series of spikes, averaged, done a dipole analysis, overlaid it on the MRI, and the kind of things that would be a routine procedure as part of pre-surgical planning, not as part of the daily note in somebody undergoing video EEG monitoring. So with that, I hope I haven't run over time. I'm going to stop sharing the screen and turn it over to Mark Newer, who's going to take over another aspect of this. Thank you very much for your attention.
Thank you, Greg. So let's talk about what to do with the outpatients. This is changing topics because now we're talking about clinic, outpatient clinic, and what to do with the evaluation and management coding for your patient care in the clinic. These are codes which are new for 2021, so they go into effect on New Year's Day. There is our learning objectives for this are to understand the codes that have changed, what are the new definitions, and how to use two of the additional codes which will probably be used in many circumstances, the prolonged service and the new specialty expert effort code, sometimes now called the added complexity code. Conflicts, I'm a shareholder in Corticare, which actually does not have anything to do with these E&M codes. So which codes are new? This applies to outpatient, new and established visits. That's CPT 99201 through 215. The old coding rules still apply to inpatient, observation, emergency department, consultations, and all other E&M codes. The new rules for outpatient clinic visits say you no longer use the history or physical bulleted system of counting elements. Only time or decision-making count for the new rules. Decision-making has been simplified slightly. Time is clearly the easier way to code. So let's talk about time first. Total time today. The time limits for the levels 1 through 5 are easy to remember. For new patient, it's 15, 30, 45, and 60. And for established, it's 10, 20, 30, and 40. So for an established level 4, you document total time today and give the time, which is between 30 and 39 minutes. If you hit 40 minutes, then total time today gets you a level 5 outpatient visit. Total time today has been redefined. It no longer is the face-to-face time with the patient. Now it includes all time that you spent that day dealing with that patient's visit or care. All the time you spent before the visit, the time you spent during the visit, the time ends at midnight. So Cinderella's coach will turn back into a pumpkin at midnight. So if you do your note in the EHR before midnight, that time counts. If you do it the next day, that time does not count. The RVUs for outpatient services increased. Level 5 increased by 33% for established and 28% for level 4. This more than accommodates the 10% cut that the conversion factor has. And of course, these RVU increases will apply not only to your Medicare patients, but they, in general, will be used across the board for your commercial, Medicaid, and other patients too. So let's talk then about decision-making rules. The old rules were more complicated. The new rules are somewhat less. The biggest change is in risk, because in the old rules, risk applied to the patient. How much of a risk is the patient's presenting problem? That's no longer the case. Now risk only applies to the test or the treatment that's recommended at the visit. If you order a procedure like major surgery, that's risk. But just seeing the patient and writing a prescription in general is not risk. So let's talk about the 3 elements within medical decision-making. There's number, there's data review, and risk. So number, how do you get to level 4 or 5? Level 4 is a patient with a chronic illness who has not yet reached the stable, or 2 patients, a patient with 2 chronic illnesses which are stable. Stable refers to meeting the clinical goal. Has it been reached and maintained? So for a patient with epilepsy, the goal is no seizures, no side effects. If they have not reached the treatment goal, that's level 4. Chronic illness, not yet stable. Level 5 requires a little more. Significant risk of morbidity, where morbidity includes limiting the patient's function or impairing the patient's quality of life. And the little insert I have here is of a patient driving, because inability to drive impairs quality of life. So that would qualify as morbidity, significant risk, and under number, it qualifies as level 5. Level 4 also has some other definitions. They talk about, when you talk about 2 chronic illnesses, they can't be different flavors of the same illness. For example, the patient has generalized seizures and partial complex seizures. Well, that's considered to be a cluster of symptoms. They're not 2 separate illnesses. Also, comorbidities are considered separate if you've addressed them at that visit, and they carry some risk. Depression and anxiety being problems that may persist and impair the patient's quality of life. Let's talk about the second of the three elements in decision-making, data review. Level 4 is when you've achieved one of these three categories, A, B, or C. Level 5 is when you've achieved two of these three categories. A is you've interpreted independently an EEG or an image. Patient brought you an EEG that was run elsewhere and interpreted elsewhere. You looked at that EEG, that counts. Patient was seen in the emergency room last week. They did a CAT scan. You reviewed the image, that counts. The B is a discussion with a physician outside your group or subspecialty. That could be talking to the patient's psychologist about the depression, or talking to a physician in a different specialty about a concurrent medical problem. 3 is a point system. You get 1 point for every test that you order, or for every test that you review. You also get a point for having an independent historian in the visit. Each test means a separate test. Like, you cannot count a white cell count and a red cell count as being two separate tests. They're both part of a CBC. But each unique test does count once. You can order a drug level, a CBC, and a comprehensive metabolic panel. That's 3. That's 3 points. But you can't count it on a prior visit as a test ordered and still count it on this visit, the new visit, as a test reviewed. You can't count that test on both visits. Also, you cannot count a test that you've also independently interpreted, such as an EEG. If you interpreted and billed the EEG last week, you can't count that again during this visit. So let's talk about risk, the risk of the testing, the risk of the treatment. Prescription drug management gets you to level 4 on risk. You actually have to do something. You can't just simply renew the medicine. You have to at least discuss changing the timing, changing the dose, changing the formulation, doing something. And level 5 is a high risk of morbidity from the test or treatment. Obviously, that would apply in oncology to chemotherapy. Drugs that need testing at least quarterly to avoid morbidity or mortality. Or a decision about hospitalizing. If you decide to hospitalize the patient, that qualifies as level 5 risk. As we said before, risk no longer will apply to the patient's condition. It applies to a probability of an event that you're considering. But the book does say that if you are ordering a test or doing a procedure with a low probability of death, that still may be high risk for that patient. Let's look at examples. Level 5, outpatient clinic, using the decision-making rule. 30-year-old woman, still having seizures and suffering from depression. Under number, this qualifies as a significant problem. It's not yet stable. It has a risk of mortality because we know the death rate for patients with epilepsy is several times that of an age-adjusted norm. So qualifies as a level 5 under number of problems. Data reviewed, let's say you reviewed an EEG or an image Maybe you discussed it with a psychologist about her depression. uh, and you ordered some more blood tests or reviewed the outpatient note from the psychologist. All those count. You've now hit all three. You only needed 2 for level 5 for data reviewed and amount or complexity. You don't have to do risk because risk, you only need 2 out of 3 to get level 5, and risk then is more than needed. So level 5 using time. So let's say instead of using this bulleted decision-making system, you wish to do time. A 35-year-old man still having seizures. He's an established patient seen in clinic. Total time today is documented in the note as 40 minutes. You may or may not wish to put in what you spent the time doing, but you at least need to say total time today, 40 minutes, or a larger number. That's established outpatient level 5 by total time today. So total time today might be all sorts of things preparing, all sorts of things during the visit, or talking to the family or caregiver after the visit, independently looking at lab results at any time, as well as writing your note. If it's done on that calendar date, it counts. Let's talk about the additional codes that you also should be using in clinic beginning New Year's Day. Not only can you bill level 5 for time, but if you now spent at least 15 minutes beyond that base time that we gave you, the 40-minute for established, level 5, more than 15 minutes, you can also code the prolonged visit code. So at 55 minutes, prolonged kicks in. Prolonged also could apply to time beyond the level 5 new patient visit. So new patient hits 75 minutes, you document total time today, 75 minutes. You use, in that case, new patient level 5 plus prolonged service. Now here's another new code that's thrown in, added complexity. Many or most, possibly all of your visits should include this additional Medicare HCPCS code. It's not numerical like a CPT code, but it's for added complexity. Medicare does pay this. We have yet to figure out which of the commercial carriers will pay this, but G2211 will add additional RVUs for the fact that you're dealing with a patient who has complexity to their patient care. If it's a patient with seizures, you're throwing this in. So now you're going to code 3 codes on that one visit. Prolonged service, here's some rules about that. Time has to exceed level 5 by 15 minutes, time that day. Remember that only attending time counts for total time today. You cannot count the resident's time. So if the resident is doing most of the visit, you may have to use decision-making to get the better way of coding. You can use prolonged service multiple times that day. So if the visit goes 30 minutes more than the base time of level 5, you can code prolonged service with 2 units of service, meaning now it's 30 minutes beyond base time. That's how you use it multiple times that day. Example of an outpatient with prolonged service, the 35-year-old man still having seizures, established patient. Total time today, 55 minutes. Code as level 5, plus code as prolonged service, plus code added complexity, G2211. We'll have time later for questions. Thank you for this. I'm happy to take questions later on during that session. Now we'll turn it over to Sue Herman.
All right, so thank you very much. I'm going to give you an update today on the Medicare policies on physician services, payment rates, and telehealth for 2021. None of my disclosures are relevant to this presentation. So for today, we're going to try to teach everyone how to perform accurate coding and billing for EEG and E&M epilepsy services, determine the impact of the CMS final rule for technical EEG services, be able to use the CPT codes appropriately for telemedicine E&M services, and then describe the impact of the OPS outpatient prospective payment system changes on EEG and epilepsy services. So the Centers for Medicare Services released the Medicare final rules on December 1st and December 2nd. So both for the Medicare physician fee service as well as for the OPS. And these policies and payment rates in the final rules will go into effect on January 1st in 2021. The Medicare waivers and other changes that have been allowed during the public health emergency will remain in effect for the next month and a half or so, but are set to expire on January 20th unless the public health emergency is extended. So the Medicare physician fee schedule is typically how providers are paid for the services that they provide. And this includes the relative values for all physician services. And this includes the professional components of long-term EEG and video EEG, as well as the evaluation and management or E&M codes. Now the fee schedule is different for Medicare. So this sets the payments for Medicare, but many insurers use these RVUs as well. We're going to talk a little bit later about the conversion factor, and that applies to Medicare, but each insurance carrier has its own monetary index or conversion factor that they use to determine the payment rates. And so when we talk about changes in those conversion factors, we need to distinguish between what's going to impact Medicare payments and what's going to impact private insurers. In summary, the RVUs for the long-term EEG and video EEG services are approximately the same as in 2020 when they first took effect. And the RVUs for the outpatient and the office E&M services are increasing, as Dr. Newer just explained, and that's going to impact Medicare and many Medicaid services, and may also have an effect on privately insured patient services, depending on how your contracts are done with those private carriers. So this is a summary of the Medicare physician's fee schedule. The two codes here, 95718 and 95720, are the 2 to 12 hour code with video, and the 24-hour code with video. And you can see that the RVUs for those 2 to 12 is 2.5. And the video EEG 24 hours is 3.86. So these are the work RVUs. This is the component that goes into most physicians' productivity schedules. On the other hand, there are components that go more to the institution. So the facility practice expense, this goes to pay for the cost of the software and the other staff required to do the professional component of these codes, and then malpractice RVUs. And so when we add all of these together, the total RVUs for video 2 to 12 hours is 3.9, and 24-hour video EEG is 6.02. And this translates into, with the conversion factor proposed for 2021 of $32.50, per RVU to about $120 per 2 to 12 hour study and $195 for a 24-hour study. And then the other components are the outpatient codes, and this is a approximately 2-day, 3-day, and greater than 4-day study for outpatient video and non-video EEG monitoring. And you can see that the RVUs are ordered. This is what the relative and relative value means, that the longer the study and whether or not it has video included in it affects the amount of points that you get towards the RVUs. So as I mentioned, the professional codes are not changing for the Medicare physician fee schedule. Now, when we look at the technical component codes, when these codes were initially proposed, the CMS didn't finalize national relative value units for these technical codes, and therefore the payment rates for Medicare were set by the regional Medicare administrative contractors, or MACs, for 2020. And private payers set their own rates by whatever negotiation process your facility typically does with private payers. And that's pretty much the same situation for 2021. So again, there are no national RVUs for the technical component codes, and Medicare contractor pricing will be the same as for 2020. There is the possibility that Medicare may create national TC values in the future, but there needs to probably be another assessment of the cost associated with providing these services before those national values can be set. A couple of people have already made reference to the changes that are going on in the conversion factor, which is great because you didn't hear it first from me. You get a little bit of a harbinger of what's coming. So CMS is actually proposing a conversion factor of $32.41 in 2021. And that's an overall decrease of 10.2% from the 2020 conversion factor, which was a little over $36. And the reason that this is occurring is because there's a requirement for budget neutrality adjustment if any of the changes in the CMS RVU values result in a more than $20 million increase in Medicare expenditures. Because of the massive changes that are occurring in E&M codes, that threshold of $20 million is met. And therefore, the Medicare payment for most procedural services are going to be decreasing in 2021 because of this 10% reduction in the conversion factor. So although your E&M will go up, your EEG services under this situation will go down. CMS estimates that on average, Medicare payments to neurologists will go up by 6%, but because epileptologists rely so much on the procedural codes for video EEG, long-term monitoring, most of us will experience a payment cut when we're reporting our procedural services, and probably then overall we'll have a reduction in the reimbursement for the overall services that we provide. Now, there is still a chance that this may not happen. There are two bills that are proposed. One is a one-year waiver of the budget neutrality adjustment requirement, and the other would maintain the 2020 conversion factor for 2 years for all of the services other than the E&M services that have had RVU increases. And this might provide some protection over the next year or two that would prevent this 10% decrease from going into effect. We're thinking that this will probably happen, although it's not for sure. Both of these bills would significantly increase the overall cost of the Medicare services, and so it may not pass. Some people think that it would exacerbate the SGR, the sustainable growth requirements that are used to maintain budget neutrality. But we're hoping that they will be sort of reversed by legislation, and that these 10% cuts won't go into effect. Maybe the payments will come from COVID resources, et cetera. And if these actually are reversed, NAEC will provide an update and send notification to all of our members, and it will be publicly available on our website. So check back over the next couple of months to see whether this 10% reduction is going to go into effect or not. And remember, this conversion factor applies just for Medicare and some Medicaid, and really does not necessarily apply to your private payers. And so although there's a reduction for Medicare services, this may not be the case for private insurers. The other thing I'm going to talk about is Medicare telehealth changes. I think by now most of us are familiar with the changes that went into place during the public health emergency, but I'll just review them quickly. So in March and April, there were multiple rules that expanded Medicare and Medicaid coverage of telehealth services, that waive the requirements of existing telehealth, and also allows telehealth to be used to supervise residents and other ancillary personnel. And these remain in effect during the public health emergency, and this has now been extended to January 20th, and we're hoping, and it looks like it will need to be extended even beyond that. So these changes really allow a marked expansion in the ability to provide care over telehealth. The telehealth services with a video component are now paid at the same rate as face-to-face services, and this applies to outpatient visits, observation and discharge day management, and initial and subsequent hospital care codes. So many of the things that we do on a day-to-day basis are now allowed to be paid at the same rate as a face-to-face visit would be. In addition, audio-only telehealth services, so phone visits using the CPT codes of 99441 to 443 are now aligned so that they're very similar to the payments for level 2, 3, and 4 outpatient E&M codes for established patients. So they don't really meet the levels that we would get for new patients, but they're quite comparable now to the level 2, 3, and 4 codes for established patients. And these are, you can see the values down here ranging from 46 to 110 for 5 to 10 up to 21 to 30 minutes of medical discussion. And this has really provided a significant improvement in our ability to provide telehealth services during this emergency. These expansions are largely being followed by the private payers, but it's almost impossible to keep up with which payer is paying for what. Largely, most of the payers are allowing these same changes to occur, but you really need to check with the individual insurance carriers to see which of these expansions are being allowed. In addition, there were other allowances that are occurring during the public health emergency, including being able to provide telehealth services to all areas of the country and in all settings, including the patient's home. They don't need to be in a specialized telehealth provider place of service. The patients can be new or established, and so that removes barriers to seeing patients by telehealth who are new to the practice. The patients no longer need to provide written consent, and they don't need to go to a specific telehealth site. Physicians are allowed to reduce or waive copays for telehealth visits, and physicians licensed in one state can now provide services to Medicare beneficiaries in another state. And again, these rules are largely being followed by private payers, but not uniformly. So you need to check with each insurance carrier. Now, what are we looking forward to in 2021? So CMS isn't extending or making permanent these telehealth allowances or the increased payment rates. These will only continue if the public health emergency is again extended. CMS feels that legislation is needed to make any of these changes permanent, and they actually call for a study on these telehealth flexibilities and whether to make them permanent. And so we expect to see significant activity towards this, particularly as the end of the public health emergency is in view. In addition, CMS did not extend coverage for the audio only. So we're all aware of the fact that many patients are not able to do video telehealth at home. And so audio only will not have the increased payment after the public health emergency. There is a new audio only code, G2252, and this will cover 11 to 20 minutes of a medical discussion to determine whether a patient needs an in-person visit. And this corresponds to 0.5 physician RVUs. So this may be very, very helpful when you're trying to determine whether somebody needs to come in for an actual physical visit. And in addition, CMS will use allow a teaching physician to use audio and video to supervise residents beyond the public health emergency, but only for patients and residents in rural areas. So this is one of the things that will be extended beyond the public health emergency, but putting back in place some of the limitations of the patient needs to be in a medically underserved area or a rural area. Okay, so the other component to talk about is the outpatient prospective payment system, or OPS final rule. And this rule covers hospital facility cost, including equipment, supplies, and labor. So this is the sort of the technical code for services that are provided in a hospital setting. And in this system, services that are clinically similar and require similar resources are lumped together in payment groups called ambulatory payment classifications, or APCs. And each of the APCs has a separate payment rate, and that's what determines the unique facility cost for each APC. And in this system, the physician or the non-physician Medicare provider services are paid separately under the Medicare physician fee schedule. So this doesn't affect the physician or other provider payments, only the sort of quote unquote technical components of the services. And overall, payments under OPS are increasing by about 2.4% for 2021. And the APC assignments that were established for the long-term video EEG codes in 2020 are remaining pretty much unchanged in 2021. So when we look at these codes, you can see that they're sort of lumped in together. So here are the technical components of the long-term video EEG. So setup and takedown, and then all of the short, less than 24-hour codes are lumped in together in this one APC called Level 2 Diagnostic Test and Related Services, 5722, which pays about $270. And then there's a slightly higher intensity code, Level 3 Diagnostic Test. This includes most of the 24-hour codes with monitoring without video, and then some of the shorter codes for here, the continuous monitoring for 2 to 12 hours, and then unmonitored and intermittent monitoring for the 24-hour codes. So these all get lumped together for about $500. And then the final highest level code is continuous video EEG monitoring per 24 hours, level 4, for about a little over $900. And remember that this only applies to outpatient studies. This is not the payment that you get for inpatient studies, which are largely covered by the diagnosis-related group payments for the diagnosis that the patient was admitted for. So this is only going to apply to your largely your ambulatory studies. So in summary, the impact on clinical care and practice, the RVUs are increasing for the outpatient and office E&M codes for Medicare, Medicaid, and also private insurers because the RVUs are going up. The RVUs are largely unchanged for EEG, but we're expecting a 10% decrease for Medicare because of the change in the conversion factor. There are still no national RVUs available for the technical component codes. The Medicare payment rates are done by regional MACs, and private payers set their own rates, and these generally need to be negotiated. And again, these are for RVUs that are for technical codes that are provided not in the hospital and not in a hospital-based ambulatory center, but in a private practice, more or less. The telehealth changes during the public health emergency are in place until mid-January, and then we don't know what's going to happen, but I think we can expect that these will need to be extended, and the OPS payments are increasing slightly with no change in the APCs for EEG. All right, so that ends my part of the discussion, and we will now open the floor for questions.
And if the panelists can all, open video and open their mics. We've gotten, and thank you to all of you, a lot of information and a lot of questions. I thought I'd start with the video EEG codes, and there are a set of questions that are kind of around a real life scenario, excuse me, for a patient that is admitted, let's say at 3 o'clock in the afternoon. Their hospital typically counts 24-hour periods at 7:30 or 8 a.m. If somebody could go through how to report, I think let's start with the PC codes and then the TC codes for like a 3-day stay. We've got questions about the short 2 to 12-hour code. Should you do it at the beginning, do it at the end? I don't know if Dr. Barkley, you want to start with that.
I interrupt you for just a moment before that
Sure.
to introduce you, Ellen. So Ellen
Oh,
Riker is
sure.
the Executive Director of the National Association of Epilepsy Centers. My apologies, I didn't introduce you before at the beginning, so she'll moderate our question and answer session. And also to take the chance, the bully pulpit, to say all of these questions have an answer that is generally reliable, even when the procedures don't make any sense. So starting with the answer to this question, maybe I'll set the stage and then turn it over to Dr. Barkley just to clarify the question. A patient's admitted at, let's say, at 3 p.m. one day, and at your institution, you write the reports in the morning and stop the studies and restart them in the morning. So normally your thinking goes along, I've written a report from 3 p.m. till 6:30 a.m. this morning, and today there's going to be another recording session from 6:30 a.m. today to 6:30 a.m. tomorrow. And I'll write another 24-hour report. So I'll write a report for the first portion of the day, and then I'll write a report for the next portion for the whole day next time. So asking that way, Dr. Barkley, why don't I just write a report today for that partial day? Let's say admitted at 7 p.m. Sorry, admitted at 7 p.m. So admitted at 7 p.m. So why don't I just write a report for the partial day from 7 p.m. to 6:30 a.m. and write a bill of 12 hours. In the next 24-hour period, 6:30 a.m. one day to 6:30 a.m. the next day, and write a report for the next 24 hours and bill for 24 hours. So 2 to 12 hours for the first part, then 24 hours for each subsequent 24-hour period after that.
So first of all rules are made because somebody tried to cheat in the past. And so we have to keep that in mind for any kind of regulatory system that's set up in any field. And so you have to look at this as an auditor looks at the encounter. And so when an auditor looks at a person who's admitted for several days for monitoring, what the auditor is going to do is say how many hours of monitoring were done. And we'll divide it into 24-hour segments. And if it rolls up to 3 24-hour day segments, it's fine. If you end up putting out 4 codes for that, you're going to end up getting a red flag, and then they're going to start scrutinizing your billing. So one of the reasons why you can't use the short code at the beginning is because you don't know how long the recording is going to last and when it's going to end. That is the practical point of it. The second thing is that it may mean that your last day of reporting may be with a code that is longer than 24 hours by a little bit, just because you can't overdo the billing, because if you said your first report was from 3 p.m. to 9 a.m. and then it ends up at 3 p.m. on the last day, then you've got to make sure that when somebody looks at the total sum of billing for that entire recording, that the professional fees equal to the amount of time that's being asked for by the duration of the codes. The second point is that for the technical component, hospital coding and professional coding have not been linked ever, in the sense that hospitals always have gone from midnight to midnight. And the rules about the hospital recording don't necessarily line up. We may try, based on a local practice in our unit or your unit, to try and make the technical components the same. But in some hospitals, they do their billing independently of whatever the physician submits, and they've always done it that way. And so you can't control what other people are doing with their bills. I hope that doesn't sound like I'm being evasive, but the hospital.
So what you're saying is that the next morning at 6:30 a.m., I write my report that covers from 7 p.m. the next day to 6:30 a.m., which happens to be less than 12 hours. And 6:30 a.m. the next day, I write next report that covers the previous 24 hours. But as far as billing goes, a billing ELF is going to decide that it started at, the whole thing started at 7 p.m. They're going to bill from 7 p.m. on the day of admission to subsequent 7 p.m.s on each subsequent day. And at the end, they'll figure out, unrelated to how unsynchronized with our reports, we'll come up with a sequential number of billings that don't coincide with our reports.
Right. So you will, in your situation you just gave, you'd say to the techs, make us stop and start at 9 o'clock, because that way I've got greater than 12 hours. My first report is 95720. And then it's clear where you've exceeded the 12-hour threshold, and you've got that all taken care of, and you're just anticipating where the next day's worth of billing is going. So there's a little bit of gamesmanship you have to play when you have to say, if I get audited, how am I going to be in the best defensive posture so that it looks like I'm not trying to pull a fast one?
So it would have been logical to allow a partial day at the beginning and a partial day at the end, but right now it's just allowed one partial day. And the CPT assistant, it says that one partial day must come at the end. But it doesn't say that your reports have to be synchronized with the billing dates. Is that correct?
It does. It's not. It isn't spoken. It just says the only thing you can be assured of is you can only do one partial day in the series of daily reports.
And Greg, the date for the reporting the code is the date when the recording starts, or
Yes.
when it's okay, not when it's read.
No, it's the day it starts.
Okay.
Procedures are dated at the time they start.
Okay.
So if you did a clinic visit, if you saw a patient at 5 minutes to midnight, the note goes in on the day at 5 minutes to midnight on that day, not the subsequent day. If you did an LP at 5 minutes to midnight, the LP goes in at the day you did the procedure. All procedures start on the day of where the procedure starts, and if it goes over midnight, so be it.
Okay. And how about when the patient has to be unhooked or disconnected during the inpatient stay? How does that impact the codes?
There is more leeway for professional coding than the technical codes. So the professional code has to be 12 hours and 1 minute to do 95720. So you could send somebody off for ictal-spect or CT scan or whatever. But if that total monitoring exceeds 12 hours and 1 minute, it's a 95720. On the other hand, if the patient's gone, if you were doing continuous monitoring, you send them off the floor. Well, now it's intermittent monitoring. And if that time off the floor exceeds 2 hours, then it's now unmonitored. So that the bar for intermittent and continuous monitoring is much more stringent than it is for the professional code.
But again, most of those codes are going to fall under the DRG and aren't going to be separately billable anyway. They may make a difference in terms of your own hospital sort of assignment of the cost of technologist services, but they're unlikely to be reimbursed separately from the DRG. That isn't true for every single payer, but for the majority of payers, that's the case.
Right, but remember, this is a team sport, and if you, the hospital has to submit their cost accounts every year. And if you can't come up with cost accounts that make your EEG monitoring unit look like it's breaking even at least, then they're going to start cutting your staffing. So you don't want to get into a death spiral of end up with nobody getting monitored, and then you've got all the issues of unmonitored people seizing, and we know what kind of a clinical issue that would create.
One of the questions we got.
Sorry,
is
before
in-
you go on, Ellen, I just had one more comment about the issue of partial days. So, for the epilepsy monitoring unit, it's much less common for that to be an issue. Most of the time we admit patients in the morning, and so we'll meet that 24-hour bar by the next morning. We actually keep a specific time to start and stop our studies of 5 a.m. or 6 a.m., 5 a.m. for the ICU, 6 a.m. for the epilepsy monitoring unit, because we feel that it's more reasonable to be consistent than to try to change the time to meet that more than 12-hour cutoff. That looks a little suspicious. It's much more of an issue with the studies for ICU, which can begin in the middle of the night. And so if we have a very short study, we may actually just bill for a extended EEG rather than a long-term video EEG study at the beginning, and then that gives us the flexibility to bill a partial day at the end.
The ICU monitoring can be like a 3-ring circus with people being hooked up and unhooked, off for CT scan, back, off for angiograms, all kinds of nonsense, or not nonsense, clinical stuff that's important, but really makes it difficult. Of course, they want the monitoring now, and then the tech gets there and they have to wait because the patient has got 3 or 4 other things that are now suddenly more important than the EEG. So we've all been there. And it's very difficult, and it creates a lot of extra work for the neurology team or the epilepsy monitoring group, both the physicians and the techs, when you have all that going on.
We had a couple questions that are kind of related to the hospital and the DRG system and the fact that the hospital is getting a bundled payment. One question was, does the hospital have any incentive to support continuous monitoring or intermittent monitoring, or in their view, because the money stays the same, would they rather just have unmonitored services provided? Just the whole question, because of DRGs on the technical side, what are the hospital's incentives to address, I think, the safety issues and the issues that the epileptologists have in wanting the test to be monitored?
I think the safety issues are probably the biggest, right? So unmonitored puts them at significant risk for adverse outcomes and malpractice suits. And so that's the argument that we use with our hospital services. But, as Greg said, there are also calculations that are done internally that the hospital then uses to negotiate DRG payments with the insurers. And if they are providing high-level service like continuous monitoring of EEG, that allows them to charge a higher rate for those services. So it is still useful in sort of cost reporting to have the higher level services.
And also for those members of NAEC, it's required for, or is now or is about to be required for NAEC accreditation.
Right. So I was just going to say that one of the fortuitous cold calls that I got years ago was from somebody from the U.S. News and World Report that wanted to know what an epilepsy center was. And because we were able to get a specific niche the neuroscience criteria for in the U.S. News Report for Level 4 Epilepsy Center, that can be the driver for our services, just as the comprehensive stroke programs have all kinds of supports that they've built as part of the Joint Commission awarding of a comprehensive stroke center. So this game can be played both ways.
So we have a lot of questions to answer, and I'll make sure we get to them, but this question of durations all the time. So a lot of these are open a little bit to interpretation. I would have said that the partial day billing was open to interpretation, but the parenthetical in the CPT book says 95717 and 18 should be billed at the end. Makes no sense, but that's what the CPT book says. It doesn't, I don't think it says it about the physician part. So I guess the physician could be billed partially at the beginning.
Well, that's the physician code is the
Right.
95718.
Oh, sorry. Yeah. 95718. Right. So it does say 18 has to be at the end, which just
Right.
is really hard to wrap your head around.
Well, so this is when rules are made, they have to try and have some consistency. And so that's why you have to anticipate that when you hook up a person, you don't know how long the recording is going to end or going to go. And so one of the ways that you anticipate that final day is if you have some room to make that first report 12 hours and 1 minute, then you've got that a little bit of wiggle room for the last day. If, as Sue said, if you have a 4 a.m. hookup, you can just put a preliminary note in the first 4 hours, and then there's a whole variety. That's the kind of the art of trying to make your reports fit with the scheme that we have. The billing system is not perfect. There are lots of flaws. We had such a mess when we did this the first 4 years. We're not going to open this up again to try to fine tune it, I can assure you, until we have to.
Okay. So moving on to the next question.
Yeah, we have a couple of technical component questions about if you start you start a test and it is continuously monitored, and then for 20 hours, and then you move to an unmonitored service for 2 hours, or if the video is on for 10 hours and then goes off for 4 hours, how do you code when there's a change within the 24-hour period for the TC?
The bar is very high for the technical billing. Continuous video monitoring means exactly that. It has to be continuous video monitoring. If there's a breakdown for an hour and 59 minutes, then it becomes intermittent monitoring. But if it's for 2 hours and 1 minute, then it's unmonitored.
And how, Greg, as a follow-up, how do you prove intermittent monitoring? There was a couple discussions about auditing, and because you prune the record, are you really able to show that the tech, went in? Do you do that through the notes?
So here's I can remember when we were buying optical disc at $100 a disc. Now the EEG storage of just the EEG is cheap. And I guess I would ask, how much are you spending to pay a tech to clip a bunch of files instead of just saying save? Because you then, by saving all the EEG, you've got all the tech notes, and if there's an audit, you just say, well, there's a tech note right there, and an hour and a half later, there's another tech note, and so on. If you clip and prune, then you've got to figure out from a legal medicine point of view, how are you going to, if you get audited, be able to defend that level of service?
There was another point brought out that the others may comment on, is that if in your normal standard operating procedures, you have continuous monitoring for patients in the EMU, that could also possibly justify continuous monitoring.
Well, continuous monitoring, so there's a definition of what is required to bill for continuous monitoring, and then there's the practice of having techs watching all the video screens. And so if you have an overnight tech that's watching 6 screens, then it's not continuous by billing criteria, but the techs are paying attention to what's going on in the entire unit if that night. So I think one has to separate billing from your clinical practice.
Right, and just to emphasize that further, so we're talking about billing as an inpatient for the technical fee, which doesn't really matter in any way except in accounting purposes, but not an actual funds flow. That's separate from the physician billing. The physician billing for their professional component, as you might call it, but for the separate codes, we have physician billing. That's unrelated to all of those things. We're just doing review of the video EEG without regard to degree of monitoring. It is with regard to do you have continuous access to the recording and so forth, but it's for the physician interpretation component of it's not related to the unmonitored or monitored part.
Right. If
That's
there's six
complicated.
studies going and somebody seizes and the tech calls you up, says, hey, or the nurse calls you, there's a seizure going on, what should I do? You're there to be able to guide and direct therapy changes.
Okay.
The question that we often get is, will there be an intracranial video EEG code, or should there be an intracranial video EEG code?
I can take this one. So remember that the R in RVU stands for relative. And so what that means for each family of codes, there's a sort of general rank order. And I pointed this out when I showed the RVU values for with video versus without video, 2 to 12 versus 24, you know, the ambulatory codes, they're all ranked by the amount of time that it takes to do the procedure and sort of the intensity of that procedure. So when we looked at whether we wanted to request a separate intracranial EEG, we looked at 2 things. One, how much, or 3 things. One, how much extra work is it? And 2, what percentage of the total number of studies is intracranial versus not intracranial. So we do about 95,000 video EEG studies over a year in NAEC centers every year. And probably 10% of those at most is intracranial EEG. And then what would the impact be if we were to say, okay, our top code is now intracranial EEG. So we're going to set the RVU as sort of the maximal for intracranial EEG, which means that all of the other codes, the other 90% of the video EEG services would be valued less than that. It's very hard to get RVU's values above about 4 or maybe 4.5 because again, they're relative, and things around 4.5 are, you know, an hour of continuous ICU care for a baby and, you know, complex cardiac catheterization. And so it's, you can't really say that 24 hours of video EEG monitoring is more complex than that. You might be able to say it's as complex as that, but then all of the other video EEG codes will be valued less than that. And we just thought that that was a really big risk to say our most complex code is going to be, you know, applied only to 10%, and then everything else is going to be cut down lower. So, Greg, if you want.
I support that. Let me add a couple other points. One is we're all hourly workers, and Kevin Kerber, who's a neurologist from the University of Michigan, who is one of our RUC advisors, did a regression analysis of all the codes in the CPT book. And 89% of the value of the code is determined by the intra-service time. And so if you say, anytime you bring up a new code, all the codes in the same family have to be resurveyed. And you can only increase codes if you can show compelling evidence that the work has changed since the last time it was surveyed. And there's no way we're going to be able to ever get compelling evidence for any of the existing video EEG codes unless there's some revolutionary change in the way work is done. So it just doesn't make sense to be able to do this from the point of view of the time and expense involved and for a very small number of patients. The other thing is that all codes are based upon the typical patient. And every time we think about a code, we think about the worst possible patient, how long it took us. So that is not the rule of the RUC. The RUC is the typical patient, which means more than 50% of the patients studied by that code.
Now, Gabe, Mark's just brought up a good point about could we have add-on codes similar to the digital analysis of EEG that could be applied to the additional work that we do with intracranial EEG. So, for example, co-registration and visualization of intracranial electrodes, and those types of work. And I think that's a fair question and something that we can definitely talk about trying to introduce as an add-on to the standard video EEG, the same way you would add on for source localization. So that code doesn't currently talk about those kinds of procedures, but there's no reason that it couldn't, or we could have a similar code to cover the extra work that we do for intracranial EEG. It's unlikely to be a daily add-on, but there may be some additional information that that we could add and develop a new code on.
So this
Correct.
is a place where source localization is a perfect place to do it. Just to talk about, to address some of the other things in the chat. Remember, it's just once per coding session you can use source localization. The source localization doesn't have to be the most elaborate thing in the world. It can't just be means you looked at the EEG, but if you did any actual source localization, it counts. And in many centers, it would be simple to do that as part of their epilepsy surgery evaluation, would actually make sense. So, but remember, it can only be billed once for a recording session, and it can't just be the regular spike detection or something like that. It has to be actual source localization. I don't guess it has to be, but it doesn't have to be combined with the most elaborate, sophisticated thing in the world.
I want to make just one more comment about the EEG codes, and then I think we should probably switch over to the E&M changes that are going to occur. So there's been a few questions in the chat about why don't we do this for epilepsy monitoring unit and this for ICU EEG? They're very different, and you know, this is more important for EMU versus ICU. And again, similar to the argument about intracranial versus not intracranial, we didn't feel that we could rank order these services or try to split them out, especially since we had surveyed the membership a few years before or at the beginning of this revaluation project. And about a third of people said they were the same. A third said EEG in the EMU was more work, and a third said EEG in the ICU was more work. And so we felt trying to split this out was going to be very, very difficult and would also potentially get, you know, one of the codes accounting for nearly half of what we do less than the other code. So we decided again to make everything the same. And that's why there's some silly things like creating a summary report for ICU EEG, which may not be all that helpful.
So now it might be good to move to the E&M codes, but just to clarify the comment, I said that soon NAEC will likely require continuous video EEG. It does imply that now, but soon it will require it, and that's among the things that were deferred. But is 90% of the members said they were already doing continuous video EEG, so it should only affect a very small number of people who might not be.
Yeah, and I will say NAEC will be holding a webinar on its accreditation program in January. So we have gotten a handful of questions about NAEC accreditation, and we'll get that information out to everyone. Mark, we do have a couple of questions on E&M. People are interested in the complexity code, this new G2111 or 2211, if I got that right. Is there any criteria on how to use this code or when to use this code?
More or less, neurologists are going to use it for all of their E&M services. There are some qualifiers that have been laid out in the Federal Register. They're rather broad, and at first, for sure, use them in all your outpatient clinic E&M. It is meant to pay you for the time that you spent during the few days before the visit and the week after the visit doing other things. about this patient's care. So if you have a chronic patient or you're taking on a chronic patient, it's fair game. Exactly when we can use this code otherwise is a little fuzzy right now, but I think it was originally meant to be for services by specialists or generalists above and beyond the actual service itself, the E&M service itself, because we do work during the days leading up to and during the week after a visit, and there is no other way to pay for that.
We did get asked the RVUs for the new G code, and it's 0.33 for the physician work RVUs. It's about a third of an RVU. And in Medicare terms, it's about a third of 30.
$10.
So it's about $10.
Yeah, right.
But if you're doing 1,000 clinic visits a year,
Yep.
that's $10,000.
Mark, any changes, with the new changes in evaluation and management codes, any changes for second opinion or consults reporting?
Consults still use the old method of bulleted decision-making and bulleted history and physical. So if you're doing even an outpatient and coding it using the consult code, you have to use the old system. There is discussion about someday moving other E&M codes over to this new, simpler, time-based or decision-based system. That's still a work in progress.
Well, they actually, could I talk on that? We've actually crossed the Rubicon, and the RUC has moved that to try and value patient care at a higher value than it has been historically. And they started with the outpatient codes. Now they're systematically moving through the entire E&M book. So the ER codes are being looked at, which is what the ER physicians use, not what we use in the ER. They're looking at nursing home visits, and they're going to basically move right through the book. And all of the E&M codes are going to be revalued, presumably upward, because care is more complex. And with each upward increment of care, the conversion factor is going to go down. So the net effect is that we're going to get paid more for taking care of patients and less for doing procedures as time goes on, which is probably appropriate because it's harder to take care of patients than to do procedures. The groups that are going to suffer the most are people who are only proceduralists. Radiology is a prime example, because everything they do is procedure and there's no E&M basically in the whole radiology. So they're taking a 10% cut right across the top.
I do sit on the CPT advisory work group that is looking at all these other E&M codes. So you do have representation that is there when these codes are being discussed. I would say for neurology as a whole this year, there's an estimated 6% gain in reimbursement from Medicare. Of course, the lion's share of that is in outpatient care for the reasons Greg mentioned.
Before we close, since we are running short on time, Dr. Fountain, do you want to remind folks if they want to continue this discussion? We have this short topics session that starts at 1:15.
If you go back to the platform and log in and then look over on the left-hand side, it's called short topics over there where you might have picked sessions or other things before. So pick the short topics, and then one of the things you can select is meet the speakers. If you select that, you can then go to the room where we'll all be at 1:15.
Well, if we can figure out how to do it in the next 15 minutes.
Also, can we just make sure that we save this chat box, and we will go through the list of questions and post answers on the NAEC website. If we didn't get to your question, check back in a week or so, and hopefully we'll have them posted by then.
There were a lot of great questions that we just couldn't get to, but we're going to try and get to some of them.
Yeah, they're common questions. I'm sorry. They're common questions, so a lot of them are answered in the NAEC frequently asked questions. So in the chat box, I added the link, but all you really need to know is to search for NAEC epilepsy and go to the center resources or updates and resources, and in there I'll called center resources, and within that you can find a comment that's about the new codes, and it's a long document, so it answers a lot of questions.
Right, but every time we do this, we get new questions, so we will
Sure.
continue to answer them.
Right. So I think our time is winding down. I want to thank all the speakers, certainly, and thank all the participants who sent such great questions. And we knew we wouldn't be able to answer them all, and that's why we had to meet the speakers. So we hope we can meet all of you back here soon. Thanks.
Bye-bye.
Bye all.